Good morning, everybody. Welcome to Grand Rounds. My name is Jerry Dempsey. I'm a retired professor in population health science. This is the 37th annual Rankin Scatrude Memorial Lecture. John Rankin was a Scottish respiratory physician who moved to Madison and UW in the early 50s. He had already become fairly famous for inventing the Rankin or Glasgow scale for stroke prognosis, but his real passion and expertise was in the lung. And so he came here became head of the pulmonary division, and then he became chairman of preventive medicine in the late 1960s, and until his untimely death in 1981. Dr. Rankin really on his own, almost entirely with soft money, developed a mini school of public health and Department of Preventive Medicine, expanded it beyond just a laboratory to include economists, epidemiologists, theorists, biologists, to the point where it's become today. So he really, I don't think it's an exaggeration at all that Dr. Rankin really set the stage for the public health portion of our medical school. Jim Scatrude was a Wisconsin native. Went to medical school here. In fact, I taught him the first year that I was on the faculty in the late 60s. Then he came back in his residency and wanted to become a scientist, and joined our lab and became head of pulmonary medicine in the early 1980s. Until his untimely death in 2006. Jim was a real pioneer in the sleep apnea field. But his and Dr. Rankin's real expertise were his mentors. They were very selfless people who cared deeply about their younger colleagues and students, and set a very strong theme for the rest of us. In addition to the lectureship, each year the Rankin Scatrude Fund awards trainees in a couple of different departments, travel scholarships to go to meetings to present the research data. It's a competitive award. And over the last year and a half, with all the delays with COVID, we awarded 6 or 8 of these. And these are the names of the people. And we have one of the people here today. Hey, John, thank you for joining us. Atul Malhotra. Well, he's quite a guy. He's known him a long time, when he was a young man till now, and he's still pretty young. So Atul was born and raised in Edmonton, Alberta. Went to the University of Alberta Medical School, and his postdoctoral training was at the Mayo Clinic and at Harvard, Mass General, and the Brigham. And then his career as an academic and scientist really started in the late 1990s. He's accomplished a lot in this 20-year period. He's a terrific clinical investigator. I think he's a really good basic scientist. He really knows how to approach science in a very objective, imaginative, insightful way. He has the usual accoutrements of a top scientist, extremely well funded, very broad-based, all the respiratory diseases, done some beautiful stuff recently on long-term effects of COVID, for example. But sleep apnea is really his major expertise. So he established a group at Harvard, young people in the late 1990s through the first 10 years, for 10 or 12 years, that really came up with an imaginative ideas on what sleep apnea was like, its pathogenesis and its treatment. And then he took those ideas again to San Diego and has done it all over again. So all the accomplishments are there on paper. But what I like about Atul is how he cares about his young colleagues and mentors. And I've been around him on many, many occasions and have gotten to know these young men in both locations. Really exceptional. A real lesson for all of us who want to be mentors and teachers. He cares about these people deeply. He cares that they appreciate both the clinical and scientific side of what they're trying to accomplish. So it's a truly exceptional person. Please welcome Atul Malhotra to our event.
Well, thanks very much, Jerry, for that very kind introduction. Thank you, Dr. Schnapp and others for having me here today. I have a lot of friends in Madison, so it's great to do that. And it's great to be done with the Zoom era, at least for now, although I guess a lot of people on Zoom. I'm going to talk today about sleep apnea. I have some disclosures that are listed there. I don't think any are directly relevant to the talk, but if they are, I'll mention as we go. I just want to do a quick trivia. Jerry already covered the background, but Jim Scatcherd on the left, obviously a distinguished mentor and quite a gentleman. And Jerry Dempsey, I won't tell the stories again, but he has been amazing. He's one of my heroes, and he had all the time in the world for me when I was very junior, and most people don't, and so I'll never forget that. I'd like to talk about obstructive sleep apnea with a global kind of view, at least to begin with. We published this in the Lancet Respiratory Medicine a couple of years ago now, where we tried to estimate the global prevalence of obstructive sleep apnea, recognizing that we don't have data from many parts of the world, and using a very liberal threshold of an apnea-hypopnea index of 5 events per hour. That is a stoppage or reduction breathing 5 times per hour. We estimate about 1 billion people worldwide with obstructive sleep apnea. You might say that threshold is too liberal. So if you use a stricter definition of an apnea-hypopnea index more than 15, that is a breathing problem 1 every 4 minutes, there's really no debate that those patients need treatment. It's about 500 million people worldwide. And that problem is getting worse over time. So Paul Peppard and Terry Young, others in Wisconsin, did some of the best work in this area and continue to do so. And by the way, Paul Peppard was a co-author on the Lancet Respiratory paper I just showed. Things have gotten worse since 1993 when Terry Young first published on the prevalence of sleep apnea. In women, the prevalence has gone from 4 to 6%, in men from 9 to 13%. The reason for this increase is related to the obesity pandemic, the aging of the population, and probably improvements in diagnostic equipment. Suffice it to say, though, there's quite a few people, maybe 10% of the US population, that stops breathing once every 4 minutes when they're asleep. You might ask the question, who cares? Why does it matter? And so we published this study in the Lancet Respiratory Medicine about 7 years ago now. Raphael Heinzer in Switzerland was the first author on this paper. What we did there is we went into the community in Switzerland and did polysomnography on them, did sleep studies on people there. I can tell you the obesity pandemic is much less of a problem in Switzerland, although it's still there compared to the United States. And despite that, using a strict definition, 15 events per hour, that is a breathing problem 1 every 4 minutes, there's about 23% of women, about 50% of men had evidence of obstructive sleep apnea. Again, you might say, who cares? They're not coming to clinical fruition. They're just people in the community, leave them alone. Well, when we looked at it, the apnea-hypopnea index, the severity of sleep apnea, was predictive of high blood pressure, diabetes mellitus, and depression, all diseases we take seriously. Doesn't mean it's causing all those diseases, but it's hard to ignore these people who are afflicted with important conditions. And so there's a concept that emerges here that sleep apnea is highly prevalent. What the number is debatable and probably not worth spending a lot of energy debating how common it is. But it is important to say that not all these patients are likely to get cardiovascular benefit from CPAP, continuous positive airway pressure. People think if you treat people at random with continuous positive airway pressure, you should prevent heart disease. And I would argue it'd be unlikely that 50% of men in Switzerland would get cardiovascular benefit from CPAP, because not all are at cardiovascular risk from sleep apnea. Some are going to die of cancer, some will have heart disease for other reasons. And so I think we need to be smarter than a one-size-fits-all approach. The take-home message so far is that sleep apnea affects up to 1 billion people worldwide. The numbers vary with the scoring criteria and the equipment used. We need to think about how to address this global burden of disease. This is a study many people know about, published in the New England Journal of Medicine in 2016, the so-called SAVE study, where they use CPAP, continuous positive airway pressure, to pressurize the airway to prevent cardiovascular events and obstructive sleep apnea. And the bottom line was that it was a negative study. Therapy with CPAP plus usual care, as compared to usual care alone, did not prevent cardiovascular events in patients with moderate to severe sleep apnea with established cardiovascular disease. The study was negative, it didn't work. And for me, there were at least three take-home messages from that study. Number one is we need better therapies and better adherence. This is a well-done study, but it's done in India and China and other developing areas where the quality of care perhaps isn't what we could achieve in the United States. And so they aim for about 3 hours per night of CPAP use, which you might argue is not adequate. So we probably need better therapies and better adherence. We also need to identify high-risk patients better. As I said, it'd be unlikely that 50% of men in Switzerland would have cardiovascular benefit from sleep apnea. And so this one-size-fits-all approach probably doesn't make sense. And we need more basic research regarding underlying mechanisms, which is perhaps a shameless plug for my lab. So I did want to talk a little bit about this big data work that we do. There's an academic industry partnership called MedEx Cloud, which we work with a company called ResMed. I've not taken money from ResMed or from MedEx Cloud, although ResMed did give a philanthropic donation to the University of California, San Diego. On the cloud, there's over 5 million patients with data on the cloud, with over 13 billion nights of data on the cloud. So it's for a physiologist that studies 10 or 15 people, I'm like a kid in a candy store trying to look at a billion people. In that context, we put on the x-axis here the days or time, and the y-axis here is the adherence to CPAP, continuous positive airway pressure. Some people say nobody uses it. If you look at the blue guys here, which is usual care, it's about 70% of patients meet Medicare criteria for adherence, so the majority of people are using it. That's better than most chronic medical therapies. If you look at inhaler use in asthma or anticonvulsant use in epilepsy, it's in that range, if not worse. And so the majority of people are using CPAP, continuous positive airway pressure. However, with propensity matching, we looked at a group here that was using modern technology. That is patient engagement tools where patients get a thumbs up if they're doing well, they get helpful hints if they're doing poorly. In that context, we're seeing about 87% adherence using modern technology. And that suggests that the vast majority of people, given a CPAP, will use their equipment. And this defeatist attitude about it is probably not warranted. Now, you might argue not everybody gets on the cloud, and that's true. If you don't have access to healthcare, or you can't afford a sleep study, or you refuse CPAP entirely, you would never get onto that slide. We tried to be as inclusive as possible. We include anybody that could get a CPAP machine and use it for at least 1 hour in total. If you get a machine and plug it in, then we included you. And about 70% with usual care were using their equipment. About 87% were using their equipment with modern technology. So if that's not enough, we looked at 2.6 million patients here. We're seeing about 75% adherence based on US Medicare criteria, which is really quite good. And again, it blows away most other chronic medical therapies. And in terms of global burden, we published this a year or two ago. Look at 4.1 million patients now, and the sample size becomes irrelevant after a while. We're seeing about 74% adherence in the United States, about 72% in Brazil, about 66% in Mexico. You might argue these healthcare systems are all different, and that was part of the point. Part of the point was to say, despite these differences in healthcare systems, we're seeing sort of comparable adherence across the board. People in Mexico are often paying out of pocket and perhaps more affluent than the average person in Mexico. But suffice to say, there are data now on use of these equipment around the world. And with my role in the American Thoracic Society, I'm looking at Lynn Schnapp here, recent president of the American Thoracic Society. I think the global burden is the way we think. And so patient engagement tools I mentioned earlier were also associated with marked benefit, but grossly underutilized, suggesting room for improvement. And the Medicare criteria out to 90 days, if you look at 1 year adherence, it's still about 80% of patients using it, suggesting treatment can work longer term. So in terms of nasal CPAP, continuous positive airway pressure, it is the treatment of choice for obstructive sleep apnea. It improves symptoms, improves blood pressure. That's transformative benefits for some patients. And defeatist attitude about CPAP is not justified. But there's general acknowledgement that we need better therapies based on ongoing research, and that's sort of the focus of my talk. So I'm going to talk about sleep apnea mechanisms. There are likely to be multiple mechanistic pathways which we need to think about in order to individualize therapy. As I mentioned, this one-size-fits-all approach doesn't really work well. Patients don't all get sleep apnea for the same reason, and they vary in their clinical expression. I'll start with a semantic definition about that. Semantics here are phenotype, which is expression of disease clinically. So an obese, obstructive sleep apnea patient with sleepiness is a certain phenotype. An endotype is an underlying biological mechanism based on distinct pathophysiology. And as I'll talk about, there's different mechanisms underlying sleep apnea. Some have a control of breathing problem. Some have a problem with the muscles in the back of the throat that keep the airway open. Some have an anatomical issue, as I'll show you. There's a concept emerging that the mechanism underlying sleep apnea might affect disease expression and risk of complications. So if you have anatomically driven sleep apnea, that's one set of problems. If you have an upper airway muscle dilator problem, that's another set of consequences, perhaps. There's a woman named Li Xuan Yi, who's a PhD nurse, who was in Philadelphia at the time this was published, but she worked with us in Boston before I left there. And she looked at different clusters and looked at the different clinical phases of sleep apnea in a cluster analysis in patients from Iceland. And it turned out about a third had disturbed sleep or insomnia type of thing. About 25% were asymptomatic, and about 43% had severe excessive daytime sleepiness. Using data from the Sleep Heart Health Study and other big NIH-funded cohorts, subsequently published in the Blue Journal here, it was the 43% with severe sleepiness who were at cardiovascular risk down the road. And so randomizing 100 patients at random to get a CPAP in order to prevent cardiovascular disease is unlikely to work in more than half of the patients because it's a subgroup. They're at cardiovascular risk. This leads to this concept of differential susceptibility. You might ask as well, how do we know that there's cardiovascular consequences? Who gets sleep apnea? It's old fat men that drink and smoke. Who gets heart disease? It's old fat men that drink and smoke. Maybe it's just confounded. Maybe it's just a marker of an unfit lifestyle. I think that probably the best work, a seminal paper from Wisconsin, Paul Peppard and Terry Young shown here, was published in the New England Journal of Medicine in the year 2000, where they looked at the incidence, that is new onset of high blood pressure, hypertension, 4-year follow-up. On the x-axis here is the apnea hypopnea index, the severity of sleep apnea. The y-axis here is the odds ratio for incident hypertension. They controlled for all the confounders you could think of, and the risk was about tripled over 4 years. And there's a take-home message here for clinicians, and that is, if you have moderate sleep apnea, your risk of developing high blood pressure in the next 4 years is about tripled compared to an exactly matched control. I'll say it again because this is what I tell my patients. If you have moderate sleep apnea today, your risk of developing high blood pressure in the next 4 years is about tripled compared to an exactly matched control. There's similar data for heart disease and other things that came subsequently, but I wanted to give credit where it's due to the Wisconsin cohort. So some of you know me, I'm a sports nut. So I'm showing this for a couple of reasons. Number one, it's cool. Number two is that's Shaquille O'Neal when he played for the Celtics. I'm a hardcore Lakers fan, but he used to be a Laker, so I tolerated him. At the time this picture was taken, I'm not disclosing anything that's not public knowledge, he had moderate sleep apnea. He's an elite athlete. He looks pretty big on TV, but at the time that was taken, he was 340 pounds, 7'1.5", and he's in incredibly good shape. You wouldn't know it from seeing him on television today. But he had moderate sleep apnea. I'm just trying to make the point that there is phenotypic variability. The old fat men that drink and smoke, some of them are lean individuals that play for the Celtics. The other reason I'm showing you this is my wife says he makes me look thin. So in terms of underlying mechanisms, there's anatomical factors, which we'll talk about. There are these pharyngeal dilator muscles, the muscles in the back of the throat that prevent asphyxia and keep the airway open. The genioglossus is the one that's the most studied, but there's other muscles. The arousal threshold is a propensity to wake up. Something called loop gain, which I'll define later, and I think Jerry Dempsey's probably done the best work in that area. There's issues on lung volume, and Bob Beagle, formerly in Wisconsin, also did some of the early work in that area, and there's vascular factors we may not have time for today. So Richard Schwab at the University of Pennsylvania has done work on the anatomy using magnetic resonance imaging. On the left here is a normal individual. The right here is an individual with obstructive sleep apnea. Just to orient you, the tongue is here, the hard palate, soft palate, uvula, epiglottis is down here, the trachea is here. This area behind the palate is called the velopharynx. This area is the retroglossal airway. You can see this individual with sleep apnea, even during wakefulness, there's a lot less space back here at the level of the velopharynx and the retroglossal airway, suggesting anatomical compromise even when they're awake. But those of us who are physiologists like to measure things rather than just taking pictures. And so we measure something called the P crit, or the critical closing pressure. On the y-axis here is the P crit, and the x-axis here is the apnea-hypopnea index. So this is severity of sleep apnea, and this is the mechanics of the airway. A very negative P crit means you have to suck on the airway to close it. A very positive P crit means you have to blow positive pressure to open it. It's a very floppy airway, has a positive P crit. Very negative P crit means a very sturdy airway, and all gradations in between. So it's an anatomical variable. And if you look at that measure of anatomy in the apnea-hypopnea index, you can see it's all over the shop. Pharyngeal anatomy by this metric explains only a fraction of the variability in the apnea-hypopnea index. Why does that matter? Well, if you're to do upper airway surgery on people at random and not select anybody, some people are unlikely to benefit because they don't have an anatomical problem. Some people have such severe anatomical impairment the surgery is unlikely to help them. But for people in between, it might actually make sense and there may be some benefit. You could have severe sleep apnea and have fairly normal anatomy. You could have severe sleep apnea and have horrendous anatomy, and all gradations in between, again, suggesting physiological measurements are required to really make informed decisions. Let's talk a little bit about these pharyngeal dilator muscles. Their control during sleep is important because that's what happens when the airway starts to collapse. For those of you that don't have an interest in sleep, but you work in the intensive care units, as many of us do, the sedatives and propofol and benzodiazepines and stuff have very similar effects to sleep. And so if you think I'm not interested in this topic, then it's very much the same kind of physiology post-extubation, for example, which we all learned about during COVID. So Amy Jordan was a woman in my lab now, a professor at University of Melbourne in Australia. And she followed up on an observation by Magda Yunus up in Winnipeg. And that's that most sleep apnea patients have periods of stable breathing. If you just watch somebody with severe sleep apnea, occasionally they'll spontaneously stabilize their breathing. Spontaneously, they'll just start breathing normally, even though they're having repetitive apneas beforehand. And Amy wondered why. She studied the genioglossus electromyogram, one of the dilator muscles. She studied the tensor palatini, a different dilator muscle, and expiratory lung volume, and other factors. And it turned out genioglossus activity was invariably high during periods of stable breathing. And if genioglossus activity was high and this dilator muscle had high activity, breathing was stable. If its activity was low, there was repetitive apnea, and no other variable predicted stable breathing. So based on that and other subsequent studies, we drew the conclusion that the genioglossus was both necessary and sufficient to stabilize breathing spontaneously in obstructive sleep apnea. Why does that matter? Well, we now have pharmacological targets and electrical targets that can increase the activity of that muscle. And the prediction would be you could stabilize breathing if you can target that muscle and related muscles appropriately. So just to convince you that muscle is important, I put on the y-axis here the genioglossus. On the x-axis here is the epiglottic pressure, the pressure at the back of the throat. There's a thing called the negative pressure reflex. If I suck on the airway, the dilator muscles will activate to prevent asphyxia. And the harder you suck, the more the muscles will activate to prevent asphyxia. Again, it's exactly the same post-extubation. So on the x-axis here is epiglottic pressure. You can see this individual, if you suck on their airway, the genioglossus fires like crazy. And so this has a robust reflex. And this person is a healthy individual without sleep apnea. This individual has exactly the same anatomy. The P crit here is within the error of measurement. And this person, if you suck on the airway, the genioglossus doesn't do much of anything. They have a very defective reflex. And this person has severe sleep apnea, I would argue, perhaps because that reflex is defective. The reason that's interesting is if you study a family of individuals, it's all over the shop. Some people have a robust reflex. Some people have almost no reflex, and all gradations in between. So if I had a drug or an electrical stimulator of some kind that could activate the muscle, I would argue it's going to help some patients and perhaps not others, because if this person has sleep apnea, I would argue it's for reasons other than their muscles. Okay, so there's a guy named Mike Stankina in my lab, who's now in Rhode Island, who studied something that was published in the American Journal of Respiratory and Critical Care Medicine now 20 years ago. And the x-axis here is various different conditions. The y-axis here is the genioglossus. If you look, this is mechanoreceptive, that's pressure stimuli, and chemoreceptive, that is CO2 stimuli. If you look at baseline here, there's a certain amount of activity in that muscle that opens the airway. If you do resistive loading, which is a way of activating these pressure receptors, not much happens during stable sleep. Hypoxia, not much happens. Hypoxia plus loading, not much. CO2, there's nothing statistically significant here. But if you combine stimuli, if you provide negative pressure, that is pressure stimuli and carbon dioxide stimuli, you get more than a doubling of genioglossus activity. So why do we care? The upper airway muscles, these dilator muscles, can respond to endogenous stimuli if provided in sufficient magnitude and for adequate duration. So again, why do I care? Well, I told you before that the genioglossus was necessary and sufficient to stabilize breathing. So if I can jack up activity in that muscle using endogenous stimuli, I should have a treatment for sleep apnea, at least in a subset of individuals. So Nancy Chamberlain retired not so long ago, but we published some stuff in rats. And I'll make this sort of clinically relevant, but you can inject the tongue of a rat with a pseudo-rabies virus vectors. They can label different synapses, and so you can look at different anatomical locations. So this is the brainstem of a rat. The hypoglossal motor nucleus is shown here. The dorsal motor nucleus of the vagus is here. This is the nucleus of the solitary tract. There's an area here called the periobex. Why do I care? If I do a pinpoint injection into that area, that's what was lit up by the pseudorabies virus vectors. That negative pressure reflex that I alluded to, that activates these muscles that can stabilize breathing, I can shut them off and modulate them through this area. This area is heavy in chat. What is chat? Cholinesterase. These are heavily cholinergic neurons. They're drug targets now using acetylcholine that we think are working through this area. With a pinpoint injection, I can activate the negative pressure reflex. With a systemic drug that's cholinergic, I can perhaps modulate the activity of this reflex. And so this, we think, gives some anatomical specificity. Again, to keep it clinically relevant for a clinical audience here, from a general medical audience, there are some newer technologies. There's one called Excite OSA that's now available. I was involved in these studies, but I've not taken money from this company. I've not taken salary support from them either. There's a young guy, Brandon Noakes, in my lab, who Jerry's actually helped to mentor, who's the first author on several of these papers. So what this is a daytime muscle training activity. So you put it in your mouth for 20 minutes a day. It stimulates the muscles electrically and builds the muscles. You can see in that context an improvement in the apnea hypopnea index. Snoring gets better, mild sleep apnea gets better. And so there's perhaps a therapeutic target here where we can activate the muscle and improve the tongue strength in a way that may be clinically important. We need more definitive data on this, but at least that technology is in development. I'd now like to talk about the arousal threshold. The arousal threshold is a propensity to wake up. Some people have a low arousal threshold, meaning they wake up easily. Some people have a high arousal threshold, meaning they'll sleep through anything. I'm the father of 2 daughters. If one of them cries in the middle of the night, my wife is more likely to hear them than am I, meaning I have a higher arousal threshold than does she, although she has a different interpretation to those data. This is an example from Richard Berry at the University of Florida in Gainesville. Here's the airflow shown here. Here's the genioglossus electromyogram, the dilator muscle in the tongue. Here's esophageal pressure. Here's an apnea. It's a cessation of airflow. You can see during that apnea, there's an activation of this genioglossus muscle that's predicted to stiffen and dilate the airway. And at some point here, when the genioglossus activity gets high enough, airflow is restored. And so the genioglossus is able to restore airflow and keep this person breathing. You can see the negative pressure building up here in the esophagus is one of the activators for this reflex. The problem is this dotted line here is an arousal from sleep. This person woke up. And when they woke up, there was a surge in genioglossus activity. That's probably what restored airflow. You might argue, however, if you delayed that arousal to a later time, made the arousal here somewhere, maybe they could activate that muscle enough that they could restore airflow. Remember, that's what Amy Jordan saw before, that the genioglossus was necessary and sufficient to stabilize breathing using endogenous stimuli. And so here's an endogenous stimulus activating this muscle, but the person woke up perhaps prematurely. And so we think of the arousal threshold as a double-edged sword. A low arousal threshold could lead to premature arousal from sleep with inadequate time to build up these respiratory stimuli. And a high arousal threshold, you get substantial hypoxemia and hypercapnia with end organ impact. And so just giving a drug to somebody to raise the arousal threshold at random could be deleterious. There's therapies to manipulate the arousal threshold likely to be beneficial for some patients to allow the accumulation of respiratory stimuli, but theoretically deleterious for others. We've used various drugs like trazodone and azopiclone and other things that can, sedative hypnotics that can raise the arousal threshold, In some cases, you see benefits, but again, you have to carefully handpick the patients. This is the same slide I showed you before, but I've added 2 vertical red lines. This is the negative pressure reflex that I mentioned. The y-axis here is the genioglossus electromyogram. X-axis here is epiglottic pressure. This person has a robust reflex. This person has almost no reflex. This is a low arousal threshold shown in red. Here's a high arousal threshold shown in red. I've given a theoretical drug to raise the arousal threshold. If I do that for this individual, it makes no difference. They have such a robust reflex, they never get those very negative epiglottic pressures. And for this person, it's inconsequential. How about this individual? You've raised the arousal threshold. They have such a crummy reflex that not much happens. The genioglossus goes up perhaps trivially. And this person, we call this a bridge to nowhere. It raises the arousal threshold, but the reflex doesn't do much. This individual, though, is more interesting, right? You raise the arousal threshold, you get more than a doubling of genioglossus activity. You would argue that stiffening the upper airway and dilating the upper airway might well be beneficial for that individual. Again, speaking to the need for individual physiology. So Danny Eckert in my lab, we published this about 10 years ago now, looking at azopiclone or Lunesta, which is a commonly used sleeping pill, hypnotic, which can raise the arousal threshold. If we did that in carefully selected patients, the apnea-hypopnea index in the y-axis, placebo or azopiclone here, you can see a statistically significant improvement in sleep apnea using that drug. Now, primary care docs will say, should I start using that in sleep apnea? No, you have to be careful about selecting patients and not just doing it at random. You can see none of them got worse in this particular study. Some got into a range you might consider cured for their sleep apnea, but there's still a fair amount of residual disease on average, suggesting perhaps combinations of therapies are required to eliminate sleep apnea, but at least the idea of giving a drug for this condition is viable. And I often get the question, how do we know what's going on? So if I'm a doctor seeing a patient in the clinic, how do I know who's got a low arousal threshold or anatomical compromise or that without doing an experiment? But right now, it's an MD or PhD staying awake all night, trying to make all these measurements to decide who goes in which category. That's not clinically viable. So we've been working on trying to make some of these data more clinically accessible. So if I'm a clinician seeing a patient in clinic, can I tell who's got a low arousal threshold? Short answer is yes. So we published this in the American Journal of Respiratory and Critical Care Medicine a few years ago now. The arousal threshold shown here, the total apnea-hypopnea index, so you can see the more severe sleep apnea has a higher arousal threshold. The nadir saturation, how much they desaturate, is also a predictor. The arousal index is a predictor, and then whether they have hypopneas or apneas, reductions versus cessations in breathing is a predictor. If you put all that into a multivariate model, I can explain more than 60% of the variance in the arousal threshold predicted by clinically accessible data. So if I'm a clinician in clinic, I can look at a patient and say, okay, you fall into this category. The clinical prediction of the arousal threshold may help to guide the response to these set of hypnotic agents and could help in the design of clinical trials, right? Because I could stack the deck in my favor and only enroll patients who are likely to respond. There's an analogy here that I find helpful, and that is we do this expensive test, the polysomnography, where we measure a zillion different variables and ignore most of them. And we just come up with this apnea-hypopnea index, which is a measure of severity. The analogy is related to the electrocardiogram. If the only information I glean from an electrocardiogram is the heart rate, the EKG would disappear. I can get the pulse lots of different ways, including from a wearable. Similarly, if the only information we glean from the polysomnogram is the apnea-hypopnea index, the PSG is unnecessary. I can get it from a wearable or from a questionnaire, or from a home test or something else. So the goal is to get mechanistic insights into sleep apnea via analyses of these polysomnograms, why they have sleep apnea, what's the risk of a particular complication. So Scotty Sands is now independent at the Brigham. He trained in my lab when I was there and doing very nice work in this area, trying to predict who's got which disease, what's the risk of a complication, using clinically accessible data. And this guy, Wanshul Shin, we never published this because he went back to Korea and didn't respond to my emails, but with a blood test, he was able to tell, and with a questionnaire, he was able to tell who fell into which categories. And so we're working on different ways using metabolomics, other techniques to try and classify patients into different categories. As some of you know, there's an FDA-approved therapy now, a hypoglossal nerve stimulator. It was published in the New England Journal back in 2014. The editorial is shown there. Pat Strollo was the first author on that paper from the University of Pittsburgh. Showed the potential for hypoglossal nerve stimulation, electrical stimulation of the hypoglossal nerve that feeds the genioglossus muscle If you do that electrically, you can treat sleep apnea in a subset of patients. Right now, it's unclear which patients might respond best. The underlying mechanism of sleep apnea is likely to be an important predictor. Remember, I showed you the variability. Some people have robust reflexes. Stimulating them further is probably not going to solve their problems because their issue probably lies elsewhere. But in some patients, it may well benefit, and that's what the clinical data support. And there's different airflow patterns I won't get into today that may well be predictive of who responds to that intervention. So again, there's a clinically important point here, and that is these hypoglossal nerve stimulators are helpful for a subset of patients. We're working on the physiology to figure out who they are. John Trinder recently passed away, but was a very close collaborator of mine and good friend. And he did a lot with us on pharyngeal dilator muscle control, these upper airway muscles that prevent asphyxia. There are likely to be important subgroups of patients who respond to efforts to augment muscle activation. Perhaps targeting the subgroup would make sense in pharmacological studies or electrically or both. And increasing upper airway muscle responsiveness may actually be deleterious for patients with unstable ventilatory control. What does that mean? If you have a dynamic resistor on the upper airway, it's very destabilizing. You get marked CO2 fluctuations, as I'll explain. And it may actually be deleterious. And again, a one-size-fits-all approach where you just give 100 people at random a drug is doomed to failure. So I want to talk about this concept of loop gain. And I think Magdi Yunus up in Winnipeg and Jerry Dempsey in Wisconsin are probably the people that taught me the most about this. You might not be familiar with that term, and so I'm going to explain it carefully. Loop gain is an engineering term that describes the stability or instability on a feedback control system. So the analogy I use is room temperature. The temperature of the room right now is 20 degrees Celsius. Think about situations where room temperature will oscillate. And by analogy, think of the body trying to regulate the PCO2 of 40 millimeters of mercury. What are situations where the CO2 will oscillate? The situation with a high loop gain is one that's prone to instability. The situation with a low loop gain is one that's intrinsically stable. So for temperature, what if the thermostat was way too sensitive? If temperature is 20 degrees, if something, a perturbation made it 19.99 degrees, if that's enough to turn on the furnace, you get a situation where room temperature is all over the place and it just oscillates because the thermostat is too sensitive. And by analogy, if I have a CO2 receptor in the carotid, that for a tiny change in CO2, you start breathing like crazy, that would be a situation where the thermostat or the chemoreceptor is too sensitive, you get a situation prone to instability. What if the furnace was too powerful? So temperature in the room is 20 degrees. If it goes to 19 degrees for some reason, you blast heat all the way up to 80 degrees Celsius, you'll get a situation where temperature in the room is all over the place because the furnace is just way too powerful. So by analogy, if I have a CO2 right now of 40, I go to sleep, it's 45. If I wake up and blow my CO2 all the way down to 10 millimeters of mercury below my apnea threshold, I'll stop breathing and my CO2 will be all over the place because the furnace is too powerful, or so-called plant is too active. And so that analogy can be helpful. The other thing to think about is trying to oscillate the temperature in this room versus the Houston Astrodome. Is it easier or harder in this room versus the Astrodome? And for a given thermostat and a given furnace and a given air conditioner, is it easier or harder in this room versus the Astrodome? What's easier here, there's a lot less gas in this room than the Astrodome. And so by analogy, the size of the CO2 store in the body is also stabilized. If you have a huge store of CO2, it's hard to oscillate. If you have a tiny store, you're much more prone to instability. So why do we care? Well, if you're a cardiologist or you're a primary care doctor or anybody taking care of heart failure, you might see this breathing pattern. If you don't see it, you may be missing it. It's about a third of patients with congestive heart failure who have heart failure with a reduced ejection fraction have Cheyne-Stokes breathing. You can see a thermistor and abdominal belt here. It's a form of central apnea. There's cessations of airflow without respiratory effort. It's defined as a crescendo-decrescendo pattern of breathing. And there's three sets of consequences. One is every time there's a stoppage in breathing, there's a desaturation. Stop breathing and desaturation. It's desaturation with reoxygenation that can lead to oxidative stress and be a strain on the cardiovascular system. The other thing to point out is in the electroencephalogram, there's an arousal from sleep. When this person's breathing, they wake up. When they're breathing here, they wake up. And the reason that matters is that paroxysmal nocturnal dyspnea, a classic symptom of congestive heart failure, is almost 100% of the time related to this breathing pattern. It's rare that a heart failure patient wakes up for any other reason. And so if you see a patient that has paroxysmal nocturnal dyspnea, they probably have a high loop gain, whether you recognize that or not, meaning they have breathing instability, and that may be prognostic. The other point to make here is in the electrocardiogram, you can see a burst of tachycardia in the EKG, the surges and catecholamines that occur. And as you all know, in heart failure, catecholamines are not our friends. The reason cardiologists get beta blockers and other things is that the neuroendocrine activation you get in heart failure is partly driven by this breathing pattern. And the deterioration in cardiac function you see over time may be related to this sort of breathing pattern and catecholamine excess. You might say, I don't care about that engineering stuff, but you do care about your patient's breathing. And so this is seen in 1/3 of patients with congestive heart failure and reduced ejection fraction. It's very common. We're doing some work in Africa as well. Irina Mbanze saw this breathing pattern in teenagers in Mozambique and Maputo. This paper is just about in press now looking at this problem in Africa. In teenagers, there's people there with rheumatic heart disease, other things. 1/3 were dead at 6 months, which I found kind of disgraceful. So we're working on trying to improve that situation. So there's different ways of quantifying loop gain. They don't matter for today's discussion. The x-axis here is control of breathing instability. The y-axis here is the apnea hypopnea index, which is a marker of sleep apnea severity. And as you can see, it's all over the shot. This marker of control of breathing doesn't tell us much about the severity of sleep apnea. However, Andrew Wellman in my lab did some work on this and published this in the American Journal of Respiratory and Critical Care Medicine. We defined a group that was intermediate in terms of their anatomical predisposition. If you have a very positive peak crit, a very floppy airway, your control of breathing probably doesn't matter because your mechanics are so bad. If you have a very negative peak crit, very sturdy airway, your control of breathing probably doesn't matter because you're anatomically protected. But if you're in between, that is atmospheric, there's a very robust relationship here between the loop gain, control of breathing, and sleep apnea severity. So why do we care? Well, we have drug targets there we can look at. So oxygen is a way of lowering loop gain or stabilizing control of breathing. Acetazolamide or Diamox is a carbonic anhydrase inhibitor that can stabilize breathing and lower loop gain. And if we do those sorts of interventions, we can see improvements. So Brad Edwards, now back in Melbourne, Australia, has done some nice work in this area. Chris Schmickel is in my lab. During the pandemic, we weren't able to do experiments because the lab was closed. So we started doing systematic reviews, which Jerry hates, but that's all we could do because the lab was closed. You can see that acetazolamide in these meta-analyses, forest plots, very consistent improvement in obstructive sleep apnea, essential sleep apnea with heart failure, high altitude. You can see acetazolamide or Diamox having some benefits. So we're looking at that more mechanistically. Scotty Sands in the Brigham also did some work in this area, and I'll skip over that for now. Jeremy Orr in San Diego also published this with us in the American Journal of Respiratory and Critical Care Medicine. Just try and take a home sleep test. What you do there with one of these home tests, they're simple, cheap, accessible. You can do it in Africa. And from that, he can get a loop gain. He can get this measure of breathing instability using just a home test. And so it's making these sorts of data clinically accessible. He looks at the ventilatory response over disturbance and can make sort of endotypic assessments, mechanistic assessments, just using clinically accessible data. So we'll ideally know why a patient has sleep apnea, what's the risk of a complication, what to do about it. And so just from one of these home tests, we can decide who might respond, for example, to Diamox or acetazolamide. Similarly, Bob Owens in San Diego has done some work with some of our surgeons. Sylvia Lee is now back in China, but she did some work. If you do upper airway surgery on people, some people respond, some people don't. If you have a control of breathing problem, the surgery is not going to help your control of breathing. And so that predicts failure. In fact, a high loop gain or unstable control of breathing predicts surgical failure. If you do a uvulopalatopharyngoplasty on a sleep apnea patient with a control of breathing problem, it fails. There's other targets there, but suffice it to say, the control of breathing is important in a subset of individuals. I don't know if I should summarize this slide. How are we doing for time? Got a few minutes. Why do these endotypes matter? Endotypes or mechanisms may guide therapeutic interventions. As I mentioned, oxygen or acetazolamide might be helpful for patients with a control of breathing problem. Uvulopalatopharyngoplasty may be helpful for patients who have anatomical compromise at the level of the velopharynx. Eric Kazarian is a surgeon at USC who is a collaborator of mine, just got an R01 grant from NIH to study this further. Risk factors for sleep apnea may be related to endotypes. We know that patients with post-traumatic stress disorder may have a low arousal threshold, propensity to wake up, and we've done some work in that area. Upper airway dilator muscle dysfunction may be very common in neuromuscular disease. Sleep apnea endotypes or mechanisms may predict clinical phenotypes. So for example, sleep apnea in the elderly may have unique mechanisms which could explain why there are fewer consequences. Work from Wisconsin and other places have suggested that that may be a different disease and perhaps based on different mechanisms than sleep apnea in younger people. And then the sleep apnea endotypes may predict treatment response, and that is these patients with unstable control of breathing may get central apneas if you put them on CPAP. The low arousal threshold or propensity to wake up may develop insomnia if you put them on CPAP. And then high loop gain, as I showed you, predicts surgical failure. You're not treating their control of breathing problem by operating on the back of their throat. So I'll summarize with a couple of slides here. In the Lancet a few years ago, we published this. We looked at treatment of sleep apnea. We said that CPAP is quite helpful for patients who tolerate it. 87% of patients use it using modern technology. That's pretty good. But if they don't, there are other options here. There are other possible treatments shown here that may be guided based on underlying mechanism. If somebody has a low arousal threshold or propensity to wake up, maybe a sedative hypnotic might be helpful in a subset of patients carefully selected. If they have poor upper airway muscle function or dilator function, maybe hypoglossal nerve stimulator activation is the way to go. And there are other possibilities here. If you have a ventilatory instability or control of breathing, oxygen or acetazolamide may be helpful. And so we're trying to think about things more mechanistically. So what's the vision here? We want to identify individuals with obstructive sleep apnea, either using a blood test or a home test or a wearable technology, to make a diagnosis of sleep apnea and perhaps why they have sleep apnea. To determine optimal therapy by assessing response to various interventions and risk of particular complications. So we got some biological data on that now. We want to design some of these adaptive trials whereby patients at risk of a particular complication, you can stack the deck in their favor. So that is to say, we said 43% of sleep apnea patients may be at cardiovascular risk. Maybe put them into one trial. There's a lot of interest here in Alzheimer's. A subset of those are at risk of Alzheimer's disease. Maybe put them into a different trial. And maybe the ones that are asymptomatic, maybe leave them alone and just expectant management may be fine. Diet and exercise may be reasonable in a subset of individuals. We're also looking at identifying adjunctive or rescue therapies based on microbiome and other things. So I'll summarize a final slide by saying obstructive sleep apnea occurs for varying mechanisms, which could be used to individualize or personalize therapeutic strategies. New models and technology need to be embraced rather than being avoided. Progress will require coordinated efforts with big data, molecular science, clinical trials, and physiology, which is not dead. Drug treatment for obstructive sleep apnea may well be viable, and sleep apnea is an exciting area. The future looks bright. I'd like to thank you all for your attention. It's been my honor to be here today. I'd like to thank Jerry and Lynn and others for having me. Thank you so much.
Thank you, Atul. That was a great overview. I'm going to ask the first question. So a patient walks into my clinic with a sleep study and moderate sleep apnea. What do I do to figure out the next best therapy?
As of right now, the treatment of choice is still, everyone heard the question. The question is, what do you do with moderate sleep apnea today? And the treatment of choice as of today is nasal CPAP, continuous positive airway pressure. If you use patient education, you use art of medicine rather than just the science in terms of different mass and different education, intensive support and things, the vast majority of patients will tolerate it well. The vast majority will get a good outcome. If they're completely asymptomatic and they have no known consequences from it, then it's a conversation about risk and benefit and other things. I will say there are a lot of asymptomatic patients who actually have symptoms if you dig deeper. And so it's an individualized conversation, but I think CPAP is still the treatment of choice as of today.
And a couple of questions online.
Thank you.
Sleeping position. What's the effect? Do you make recommendations?
Yeah, so body position is something that's affected. In fact, there's a lesson here for young scientists, and that is, I used to be careful about record keeping, although a lot of clinicians come to the lab and don't understand how important it is to keep detailed records. And it turned out I was doing some studies of the patients supine and others lateral, and I wasn't taking careful note of it or careful enough note of it. It turned out we later published that there's a big effect of posture on some of these airway reflexes and things. It's just a note to self about don't ever forget to document everything when you're taking notes there. But it's quite true that in some subset of patients, positional therapy is viable. Avoiding sleeping on the back and sleeping on the side can be quite helpful. There are patents back to the 1800s where people tried to patent different devices to sleep in the lateral posture. And there's some that are now FDA approved that Philips and other companies have been pushing. I will say that the results on those things are quite variable. And in some studies out of Israel, Oxenberg has published, patients actually prefer CPAP. So it's true that positional therapy can help the mechanics of the airway by avoiding supine posture, but it's not the be all and end all.
So all of the apps that we see to monitor your sleep, your Apple Watch, et cetera, are they useful practically to monitoring patients for clinical response and in clinical practice?
So the wearable technologies I think are evolving. I'm wearing a Fitbit right now as we speak here that gives me some information about sleep. There's a guy named Ian Coleraine at Stanford Research Institute that has some concurrent measures of polysomnography with the Fitbit. It's gotten better. 5 years ago, they were garbage. They've gotten quite good now. And I think in the majority of patients, it's at least directionally accurate and helpful to classify. And I think that technology is rapidly evolving. So I think it's a matter of time that we'll have wearables. They're telling us a lot of information. The Apple Watch, unfortunately, some of their earlier versions, the battery was 18 hours. And so people didn't sleep with them. And so we didn't get a lot of sleep data because they'd wake up, put their watch on, then take it off when they went to bed. But that technology is rapidly evolving. We're working in that space, but identifying sleep stages and getting directionally accurate information is now viable. I have a lot of patients come into clinic with that kind of information, and like all consumer products, you have to take it with a grain of salt, but it can be helpful. It can be motivating for some patients too to change behavior. So Lynn is a good friend through the American Thoracic Society. Congratulations on a very successful presidency, despite the demands of the pandemic. Just flew in from New York, but been there, done that. So, hi,
Thank you, Atul, for this presentation and summary. You work in the critical care, and there is a really small group of sleep folks who do. So I asked Jesse Hall a number of years ago, and you as well, is there anyone working on the upper airway dysfunction and risk for breathing issues post-extubation? I mean, certainly these patients have so much injury, swallow dysfunction and all that. Seems to me that this could contribute to upper airway pathology. And I wonder if you or anyone else works in that space.
Yes, the question's about post-extubation airway mechanics. It's a very important topic. There are 3 different randomized trials, one by Ferrer, one by Shatina, one by Nava, all showing benefits to non-invasive ventilation post-extubation in high-risk patients, but it works preemptively. If you do it as a rescue therapy, then Esteban had a New England Journal paper showing worse outcomes. If you do it for rescue, when patients are struggling, they tend to arrest when you're intubating, so don't do that. But early on, if they're high risk with cardiopulmonary disease, neurologic disease, morbid obesity, the non-invasive ventilation can be quite helpful. High flow nasal cannula is also being used in that context. So I saw some very recent data suggesting non-invasive ventilation may be better. It's splinting open the upper airway. How do I know that the upper airway is the culprit? There's a woman named Gaytam Michaud, who's an interventional pulmonologist in Florida. But when she was up in Canada where she was born, she did a CT scan study where she CT'd patients post-extubation. And the very narrowest airways are the ones that got reintubated. The other ones did not. She never published that despite my screaming at her about trying to do so. And I offered to help her. It was never published, but I'm convinced that there is an upper airway problem post-extubation, in part from the meds, in part from just the physical endotracheal tube having been there. So I think that is an important topic. So the question is, does that persist over time later? And the answer is I don't know. There is a recovery post-extubation. People don't get reintubated 3 months later. But I think some of the benefits of tracheostomy, which are mixed in the clinical literature, may be related to upper airway dysfunction, which is perhaps underdiagnosed. We did try and do a study using pharyngometry post-extubation, trying to measure it, but it's hard to do. We didn't get decent data.
Next question. Can you comment on the role of nocturnal acid reflux in triggering sleep apneic episodes?
Yeah, so we're doing some work on that now. The short answer is I don't know. There are some theories about negative intrathoracic pressure, positive gastric pressure, creating a gradient for gastroesophageal reflux. And you might argue that sleep apnea causes reflux or promotes reflux. In fact, there was a paper in the Archives of Internal Medicine when that journal still existed about giving CPAP as a treatment for reflux. And there were some fairly major benefits. That was about 15 years ago. However, when you look at studies that have given Prilosec or Omeprazole for the treatment of sleep apnea, see whether you can reduce upper airway inflammation and treat the reflux and improve the things, those studies are negative. Similar to the asthma literature, where really people haven't shown that you can prevent asthma or improve asthma by treating reflux. I think it's an association, but causal pathways are still being defined.
And can you comment on the treatment of central sleep apnea?
That's another talk. You'll have to invite me back next year. What I will say about that is a couple things. Number one is central sleep apnea is much less common than obstructive sleep apnea. And for the most part, the treatment is the underlying cause. So if somebody has congestive heart failure with Cheyne-Stokes breathing, you optimize treatment of their heart failure with ACE inhibitors and diuretics and spironolactone, whatever else you're going to give, SGLT2 inhibitors now, I guess, that can be quite helpful in that context. And so treat the underlying cause. If somebody has opioid-induced central apnea, try and reduce the dose of the opioids, and that's part of the mechanism underlying the opioid pandemic, I think, is breathing issues like that. The other thing that can be quite helpful is reassurance. I was telling the story last night at dinner. When I was a resident, I volunteered for a research study to make an extra $100. And I stopped breathing because my CO2 was quite low. And I was freaked out. They told me there's something wrong with your brain. Your control of breathing's messed up. You shouldn't stop breathing. But as a young person, it's a perfectly normal response to hypocapnia or low CO2. So I have lots and lots of patients come see me with central apnea saying, quote unquote, there's something wrong with my brain. I think just the reassurance that it's a normal response to hypocapnia, as Jerry Dempsey and others defined decades ago, is a normal response to hypocapnia. That can be quite reassuring for people. So the short answer is treat the underlying cause and provide reassurance.
What is the impact of aging on sleep apnea?
You guys have easy questions, huh? So depends where they're going. So mechanistically, the reflexes tend to get impaired with aging. That's true in the anesthesia literature for upper airway reflexes. We had a paper in the American Journal of Medicine some years ago showing exactly that. There's an attenuation of those reflexes with aging. Control of breathing abnormalities tend to be more common in younger people than in older ones. The other part of the question, though, is related to, I think, Alzheimer's, and there's a strong interest in Alzheimer's in Madison here, so I'll just touch on that a little bit. We have an R01 grant now from the National Institute of Aging to study that. I'll say a couple of things about it. Number one is there's a JAMA paper about 10 years ago showing the incidence, new onset of Alzheimer's is increased in untreated sleep apnea, particularly in women. Number two is the ApoE epsilon 4 gene is abnormal in sleep apnea as well as in Alzheimer's, a common genetic predisposition. Holtzman at WashU in St. Louis had a science paper about 3 years ago showing disruption in sleep, both in rodents and in humans, was associated with amyloid and tau deposition in the brain. In a Proceedings National Academy of Sciences, studying people before and after sleep deprivation, the same individuals compared to themselves, you can see accumulation of amyloid in the brain with sleep deprivation. And we have a bunch of papers now on memory consolidation, where when you sleep, you consolidate memories. But we've shown that treating sleep apnea, your memory improves at 3 months in a randomized trial compared to controls, and very few things improve memory. So I think the short answer is it's complex, but there's lots of interactions there. We're very interested in the idea that sleep disturbance may not just be associated with cognitive impairment, but may also be causally important.
And then maybe I'll ask the final question unless there's one from the audience. Okay, great. So I recently bought a pillow, went shopping for a pillow, and the guy was in this discussion about how mouth breathing is much worse than nose breathing. And, you know, they were advocating these clipping your mouth shut at night to force you to breathe through your nose. So what would you tell the salesperson?
Is this Mike Lindell, the My Pillow guy? There are a lot of crazy people on TV that say a lot of stupid things. Some of them are politically active, and so I'll put the political side aside for now and just say that people make a lot of claims that aren't there. The most important thing about mouth breathing to know is that the best predictor of mouth breathing is nasal resistance. And so if your nose is occluded, you tend to open your mouth because the air goes through the path of least resistance. So for mouth breathing, the first line treatment is the underlying cause, and that is reducing nasal resistance. If it's Vasomotor rhinitis, you give antimuscarinic. If it's in Madison, so Bill Bussey, others wrote the book on this. Allergic rhinitis, you give fluticasone or nasal fluticasone. In fact, Mihaela did work on that as well. If the problem is a nasal septal deviation or polyps or something, then surgical approaches. Improving nasal patency is the first line option. Beyond that, trying to tape your mouth shut to improve your sleep or something is nonsense.
Okay, great. Thank you, Atul, for a wonderful overview, and looking forward to seeing the next grand rounds and how we be able to use a lot of these new and innovative therapies in our patients and the patient selection. I'm very excited about it. Thank you again for visiting. Thank you, Dr. Dempsey, for inviting him and for the wonderful introduction.
Thank you.
And
Hey, good to see you.
hey, how are you?
What time do you